For anyone following conversations around healthcare, the social determinants of health are a pretty familiar concept.
Mm-hmm.
But the real challenge, I think, is moving beyond just recognizing them to actually acting on them.
Absolutely.
So today we're doing a deep dive into a really insightful study from Japan by Mizumoto and colleagues. It explores exactly that, how medical professionals can better understand and truly address these crucial social factors.
Yeah, our mission for you today is basically to unpack this groundbreaking framework they developed. It aims to make these, well, often overlooked aspects of patient care not just clear, but really actionable.
Right.
This isn't just theory floating around. It's a blueprint, like for practical steps that could genuinely transform healthcare delivery.
So the core problem seems pretty clear then. Doctors know these social determinants. The conditions people are born in, grow up in, live, work, age. They know they significantly impact health.
Right. Big impact.
But what are they actually doing about them day to day in the clinic? This study highlights a critical gap, doesn't it?
Mm-hmm. It really does. Physicians often lack the explicit training, or they face these systemic barriers that stop them from addressing social needs.
Hmm.
I mean, imagine trying to treat a patient effectively without knowing about their housing, their job security, if they can even afford good food.
Yeah, it's like missing a huge piece of the puzzle.
Exactly. It's like having a critical piece, but maybe no one's shown them how to fit it in properly. And that's the challenge this study in Japan really took on.
Okay, so how did they approach something so complex? I mean, it seems deeply ingrained.
Well, they used a modified Delphi technique. It's quite a clever method, iterative, where experts refine their ideas anonymously over several rounds.
Oh, yeah.
It's not just a simple survey. It's really designed to build solid, unbiased consensus, which is so important with diverse viewpoints.
Makes sense.
And what's really fascinating here is just the sheer breadth of their expert panel. It wasn't just doctors and nurses.
Yes.
Well, sure, clinical professionals like physicians, nurses, social workers, pharmacists, but also residents, medical students, researchers, and crucially, support members for marginalized people and even patients themselves.
Wow, patients too, that's vital.
61 experts in total. So they really tried to get a wide range of real-world perspectives baked in.
Okay, so after all that consensus building, what did they actually come up with? Was it just identifying problems again, or like actual actionable steps?
No, that's the powerful part. They distilled it all down into 14 concrete, observable steps for patient care, specifically related to SDH.
14 steps. Okay.
And they structured it into what they call the CPMA model: communication, practice, maintenance, and advocacy.
CPMA. Got it.
And running through it all, the emphasis on an ongoing patient-physician relationship, and really importantly, strong collaboration, teamwork.
Okay, let's break down the CPMA model then.
Sure.
Maybe start with communication. What does that look like?
Right. So communication here is more than just the usual medical talk. It's about building a relationship where patients feel safe enough to actually discuss their social background, their life.
So real trust building.
Exactly. It's about physicians really listening to the life experiences that might be underlying the patient's behavior, not just focusing on the symptoms they present with. It even points towards a doctor's needing to address their own biases.
That's huge.
It's about truly hearing the patient's whole story.
Okay, and what about the doing part? How did that translate into actual practice?
Yeah, practice is the what to do. It involves identifying and, with consent, of course, documenting these social factors.
Documenting them.
And then figuring out how to address them. Often, this means referring patients to resources outside the typical health system.
Like community services.
Precisely. Think about a patient with, say, chronic asthma. A doctor using this model wouldn't just prescribe an inhaler. They might ask, do you live near a factory? Is your housing damp?
Connecting the dots.
Right, and then maybe connect them with local housing resources or advocacy groups. It really emphasizes that it's a team effort. A single physician can't and shouldn't try to cope with all this alone.
That makes sense. Now, the maintenance component sounds particularly unique. Why is that considered so vital?
Yeah, maintenance is maybe the most radical idea in some ways. It tackles physician burnout head-on.
No. Okay, how?
By creating space, actual structured space, for doctors to verbalize their feelings of moral distress. You know, that awful feeling of helplessness or anger when social factors are clearly blocking good care and they feel powerless.
Wow, acknowledging that emotional toll.
Exactly. The framework suggests reflecting with colleagues, processing these feelings to mitigate burnout. It recognizes that a healthy, resilient physician is actually fundamental to providing consistent quality care over the long term.
So it's not just self-care fluff, it's actually core to sustaining the system.
You could say that. It's almost patient care by proxy, sustained over time by supporting the caregiver.
Okay, and finally, advocacy. This seems to move beyond just the individual patient interaction, right?
It does. Advocacy encourages physicians to look up from the individual case and identify systemic challenges, barriers in the healthcare system itself that prevent access, or broader social inequities that impact health.
So looking at the bigger picture.
Yeah. It acknowledges that while, one doctor can't single-handedly overhaul society, they can pinpoint and maybe even address the systemic hurdles right in front of them. They can participate in actions that reduce the negative effects of those wider issues.
So this CPMA framework, it sounds incredibly promising, really comprehensive. But, I mean, is it truly scalable? Does it offer a concrete path for all of healthcare, or are there big hurdles to implementing something like this?
Well, that's the million-dollar question, isn't it? And the study itself does hint at some challenges. Remember, it was conducted in Japan, a high-income country, yes, with universal health care. But even there, they still face significant social inequities. Their relative poverty rate, for instance, is actually higher than the OECD average. So these issues are real, even in that context.
Interesting.
The real challenge, though, is figuring out how to adapt this detailed, observable framework to other countries, other cultures, and crucially, how to make sure it genuinely reflects and serves the voices of the most marginalized patients. That was a group the study itself admitted was difficult to fully recruit and engage.
That's a critical point, ensuring those voices are central.
Absolutely vital.
So maybe something for you listening to consider. What specific social determinants might be silently impacting health outcomes right there in your community? And how could this kind of framework, communication, practice, maintenance, advocacy, how could it inspire new ways to think about holistic care where you are?